This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Neurosurgical Review, published in 2026, titled Stereotactic Radiosurgery in the Management of Cluster Headache, Evidence from a Systematic Review and Meta-Analysis.
This is a heavy topic, Ilara. Cluster headache, or CH, is often called the suicide headache for a reason. For our residents listening, remember that while it only affects about 0.1% of the population, the intensity of the pain is arguably the most severe a human can experience. We're talking unilateral, excruciating attacks with those classic autonomic features, lacrimation, rhinorrhea, and ptosis.
Exactly. And while most patients respond to oxygen, triptans, or verapamil, there is that subset of chronic refractory patients who are just desperate. That's where we as neurosurgeons get the consult. Historically, we've looked at microvascular decompression or even destructive peripheral procedures, but this paper explores the role of stereotactic radiosurgery, or SRS.
Right. SRS is appealing because it's non-invasive. We aren't opening the skull. We're using the gamma knife or cyber knife to lesion deep structures with sub-millimeter precision. But the literature has always been, well, messy is the word that comes to mind. This meta-analysis tries to clean that up. What did the authors actually find?
So the authors, Haja Karim Liu and colleagues, pooled data from 5 major studies involving 51 patients. That might sound like a small number to a general surgeon, but in the world of refractory cluster headache, it's a significant cohort. They looked at SRS targeting the Gasserian ganglion or the trigeminal nerve, sometimes with concomitant targeting of the sphenopalatine ganglion, or SPG.
The dual target approach. That's been a hot topic lately. If you target the trigeminal nerve, you're hitting the sensory afferents, but if you hit the SPG, you're addressing that parasympathetic outflow that causes the autonomic symptoms. What was the honeymoon period like for these patients?
The early results were actually quite impressive. The meta-analysis showed an initial complete pain-free rate of about 60.1%. If you look at adequate relief, which usually means a 50% reduction in attack frequency or intensity, that number jumped to 80%. For a resident on the wards seeing a patient in the middle of a cluster cycle, an 80% chance of relief sounds like a miracle.
But in neurosurgery, the miracle often has a shelf life. What happened at the last follow-up?
That's where the data gets sobering. The durability just wasn't there. By the time they reached the final follow-up, before any salvage therapies were initiated, the complete relief rate plummeted from 60% down to 28.8%. And that adequate relief dropped from 80% to 41.7%. The recurrence rate was nearly 60%.
That's the cliff we often see with ablative procedures for functional disorders. It suggests that while we can stun the system or interrupt the trigeminal vascular circuit temporarily, the underlying pathophysiology, likely centered in the hypothalamus, is still driving the disease. As a senior attending, my concern when I see a 60% recurrence rate is, what price did the patient pay for that temporary relief?
And that brings us to the most critical part of the study, the adverse radiation effects, or AREs. In the studies with longer follow-up, they reported high rates of permanent trigeminal sensory deficits. We aren't just talking about a little bit of numbness. They noted cases of anesthesia dolorosa.
For the medical students listening, anesthesia dolorosa is the neurosurgeon's nightmare. You've successfully made the face numb, but the patient now experiences a constant, burning, agonizing pain in that numb area. It is often harder to treat than the original headache. If SRS for CH has a high risk of anesthesia dolorosa and only a 29% long-term success rate, that's a very difficult conversation to have during informed consent.
The authors actually pointed out that studies with shorter follow-up likely underestimated this toxicity. Radiation injury takes time to manifest. This is a classic example of why we can't just look at 6-month data in functional neurosurgery. We need years.
Let's talk about the targets for a second. The paper mentions targeting the trigeminal nerve versus the SPG. In my experience, the dosing for CH has often been higher than what we use for trigeminal neuralgia, sometimes upwards of 80 or 90 gray. Did the meta-analysis find an ideal dose?
Unfortunately, the heterogeneity was too high to pinpoint a Goldilocks dose. Because the targets varied, some at the retrosegmental trigeminal nerve, some at the Gasserian ganglion, the dosimetry wasn't standardized. However, the authors suggest that the high rate of nerve injury warrants a cautious and highly selective use of SRS.
So where does this leave us in 2026? If a resident comes to me with a patient who has failed verapamil, failed lithium, and is having 10 attacks a day, do we offer SRS?
The study suggests SRS might serve as a temporizing option. maybe for patients who aren't candidates for more invasive neuromodulation, like deep brain stimulation of the hypothalamus or SPG stimulation. If a patient is elderly or has surgical comorbidities that make a lead implantation risky, SRS could provide a window of relief.
I agree, but I'd emphasize the word selective. We also have to consider the emergence of CGRP monoclonal antibodies and non-invasive vagus nerve stimulation. The bar for surgical intervention keeps getting higher because the medical and less invasive options are improving.
One thing I found interesting in the future direction section of the paper was the call for standardized outcome metrics. Right now, one study defines success as no more attacks, while another defines it as I feel better. It's hard to do a meta-analysis when everyone is using a different yardstick.
That's the functional neurosurgery problem. We need the cluster headache outcome score to be universal. Also, I'd like to see more work on the SPG target. Targeting the ganglion itself rather than the nerve might spare some of those sensory fibers and reduce the risk of that deafferentin pain we're so afraid of.
Definitely. The authors also mentioned that 19% of these patients eventually needed salvage therapy anyway. So if you're a resident planning a treatment course, you have to assume that 1 in 5 patients will need a plan B after the radiation.
And plan B after radiation is always harder. Tissues are fibrotic, the anatomy is distorted, and the wound healing isn't the same. It's a reminder that SRS is not free. It has a biological cost.
To summarize for our listeners, this meta-analysis of SRS for cluster headache shows a strong early response, about 80%, but a significant drop-off in efficacy over time, with less than 30% remaining pain-free long-term. And most importantly, the risk of permanent trigeminal nerve injury and anesthesia dolorosa is real and likely underreported.
Excellent summary, Alara. My takeaway for the practicing surgeons: keep SRS in your back pocket for the truly refractory patient who cannot undergo stimulation, but be brutally honest about the long-term numbers. Don't promise a permanent cure when the data shows a 60% recurrence.
Great point, Dr. Aris. It's all about managing expectations and choosing the right tool for the right patient.
Well, that's our 10 minutes. Thank you for joining us on the Neurosurgery Hub podcast.
We'll link the full paper in the show notes. See you next time.